So,
Good.
Nelson. Yeah, so good afternoon, ladies and gentlemen. Welcome to the continuation of the Ebola Preparedness series. Our topic today is on epidemiological surveillance and contact tracing. And the speaker is Dr. Samuel Kavidene. He's the head of Integrated Disease Surveillance Unit in the Division of Disease Surveillance and Response in the Ministry of Health. So today we're basically going to talk, this is the 7th session in the Ebola Preparedness series, and we're going to talk about how to find people who have Ebola. And I'd be interested to know for how long we do the contact tracing for. And to learn more, so for questions, please put them in the Q&A platform. And for the previous sessions, you'll find them uploaded in our KNH Research YouTube channel. And for updates on what's happening in KNH Research, you can follow us on Twitter. Our handle is KNH Research as shown below. So Daktari, welcome. Thank you very much for taking your time to teach us today.
Yeah, thank you very much, Dr. Amina. The only thing I can say is that Amina has baptized me Kavidane instead of Kadivane. Okay,
Sorry,
so just a correction. It's Kadivane. Kavidane. Okay.
Kadivane.
Kadivane. Yeah. Thank you.
Nice name. Thank you.
Good.
Okay.
Yes. So this afternoon we're going to discuss about surveillance in the context of Ebola, and I have a few slides that I'd like to share. But I thought it is wise to just start by stating the current situation in Uganda as it is. The latest CITREP we have from Uganda was from as of 11th of December, and this is what the situation was. Number one, you need to know that Uganda declared an outbreak on the 20th of September, and so far we have 142 confirmed cases. The cumulative deaths are 55, giving us a case fatality rate of about 39%. The recovery so far is 87. And in terms of healthcare workers, which is what should actually be of concern to us, is that so far we have had 19 healthcare workers infected with 7 dead, giving a case fatality rate of about 37%. Of importance is also that the last positive case was reported on 27th of November. It was a dead infant. The districts affected were Mubende, Kasando, Kiegegwa, Unyangavu, Kagadi, and Kampala. Sorry. Okay. So when you talk about surveillance, what exactly are we talking about? We define surveillance.
Daktari.
Yes.
Is it possible you put it on slideshow?
Sometimes it doesn't move, but let me try.
But
Is that okay? That's fine. Okay. So as we talk about surveillance, for us, surveillance refers to an ongoing systematic collection, analysis, interpretation of health data. It includes a timely dissemination of the resulting information to those who need them for action. Summary for us normally is we state the simple thing is that we are interested in data for action. So surveillance is data for action. If the data you're collecting is not going to be useful, not be used for anything, it's better not even collected in the first place. Yeah. So surveillance plays a key role in understanding the epidemic dynamics, guiding response and monitoring of response activities. There is a systematic contact tracing, which is critical in breaking the chains of transmission. So why do we do Ebola surveillance? Number one is that we needed to confirm the outbreak. This is done by confirming it through the lab tests. Then we need to identify all cases and contacts, detect patterns of epidemic spread, also estimate the potential for further spread of the disease. And of course, of great importance is control measures. Are they working? Like in the case now in Uganda, the last positive case we got was around close 2.5 weeks ago. So we can comfortably say that possibly the measures instituted by Uganda are working, and the number of new cases coming up are it's almost zero for the last 17 days. So what are the strategies we use? Under surveillance for Ebola, we treat rumors and alerts very, very important part of us. We always have to log and verify them. Should never ignore any rumor of a particular death or somebody presenting with what we call case identifiers. Like in this case, could be talking about the fever, talking about probably some bleeding if possible. And then we also do active case search. Active case search here refers to us going back to the community and trying to establish whether there were any other cases that might have been missed at the initial time of the outbreak, maybe deaths in the community, just to find out whether there are cases that met the case definition but were not captured by the system. We also talk about contact tracing and follow-up of all contacts. Of particular importance in Ebola is contact tracing is the backbone of actually controlling the outbreak. Of course, documentation is crucial, prompt notification, and as I mentioned before, surveillance is about data for action, and data management is very critical. So what do you do before an EVD outbreak? Number one, you continue with the implementation of surveillance through the integrated disease surveillance and response that you do routinely, having priority cases that are reported on a weekly basis, monthly basis. Of course, the immediate one also counts. You also need to train personnel at all levels so as to be able to detect the outbreak. Then you share surveillance data regularly. You also encourage having a One Health approach, whereby we take notes that health issues are not just for the human health only, but we need to collaborate with the animal side, that is the veterinarians, as well as the environment side. So the three components have to be taken care of. The animal side, human health, and the environment. You also need to involve key players and partners. Then, of course, prepare a contingency plan just in case a case appears. What will you do? So during the threat, like what we have now, we have a threat of Ebola from our neighbors. What do? We, number one, activate the contingency plan. You had mentioned earlier that one of the steps that you take during, before an outbreak is to prepare a contingency plan. When you have a threat, you activate the contingency plan, which has been done so far, and you have activated the multi-sector national task force. It meets regularly, at least once a week. Then we train health personnel at all levels. This, you're already doing it. You might have heard of so many trainings being done across the country with various staffs, both at the county level and the national level. Then you establish rapid response teams at all levels. And these are the teams that normally respond as early as possible in case there's a rumor or a threat or a case meeting the case definition. We also establish an EVD alert management system at all levels. Then communicate, very crucial, as it just became clear to us. You need to communicate to the media, to the stakeholders, and to the public. At the beginning of this outbreak in Uganda, there was a lot of concern about what was being done. And as a ministry, what was done called a breakfast meeting and explained what was happening to the media and the population at large. Then share surveillance data regularly. What are rapid response teams? You need to establish them at all levels, and they need to respond to any alerts 24/7. And it is normally composed of an epidemiologist, a surveillance officer, a clinician, an IPC expert, data manager, lab personnel, environmental health, health educators, and the list goes on. What do we train them on? The rapid response team need to be trained in in-depth knowledge of Ebola virus disease, have a case identification based on case definition. We shall soon see what a case definition is all about. Personal protection, very, very crucial. Then use of the surveillance tools, the reporting tools, and the documentation tools throughout the system. Then there is a contact tracing, follow-up, as well as referrals. And communication, importantly, is line listing. Any case that meets the case definition needs to be line listed and documented and reported. So this is what we call a case definition. It is basically a set of criteria that is used to determine whether a particular person presenting meets, can be actually identified as a case. It is not based on lab diagnosis. It is just based on a syndromic approach where you have certain characteristics. For in this case, you're talking of any person with one or more of the following: acute onset of fever, vomiting, diarrhea, abdominal pain, headache, sore throat, a measles-like rash, red eyes, bleeding from body openings, and of great importance is history of travel to Uganda or contact with somebody who has been in contact with a person confirmed to be having Ebola virus disease within the last 3 weeks. The 3 weeks are due to the incubation period. The shortest incubation period is about 2 days. Then the longest is about 21 days, which corresponds to the 3 weeks. So where do you apply the case definition? Could have 3 scenarios: case detection. Scenario 1 is where the case has been detected at the point of entry screening. In this case, you could be talking about the areas bordering Uganda, Busia, Malaba, and then, of course, our international airports. And what do you look for? Move the patient to the holding area, then move the ambulance, and the patient is moved to a holding area in the isolation facility. Like in this case, I think Busia has designated Alupe as the isolation facility. Then you collect the samples, and if positive, you move the patient to the isolation. Then the contacts are kept in quarantine and followed up for 21 days. The second scenario would be where a case is detected at the health facility. In this case, the patient will be moved to the isolation, sample collected in full PPE, and the samples referred to Cambridge, which is our main facility doing the testing. In Nairobi, it goes to Nairobi, Cambridge. In the coast, it goes to Kilifi, Cambridge. And from the western side, the Cambridge in Kisumu. What of the case was in the community? We foresee a situation where the community health volunteer can be notified from the community. Then he or she notifies the next level. It is the level of the CHA, community health assistant, who is normally attached to a facility. So you need to explain to the patient and family the need for hospital care, arrange for hospital transfer in ambulance. Then samples are collected and referred to Cambridge. And if the subject has died, explain to the family the need for safe burial. Of great importance in Ebola, the most important thing to actually work on when you have a case of suspect case of Ebola is IPC, infection prevention and control. That is the mainstay of controlling an Ebola outbreak. So the need for safe burials. After obtaining consent, you then coordinate funeral arrangements with the burial team. In Ebola, we do advise that the burials be conducted in an IPC environment, and we advise that the burial team is the one to take charge of that. Then we need to notify the sub-county health office and also the division of disease surveillance and response. And if the samples turn negative, then the suspected case is released, but followed up for 21 days. Then all healthcare workers and point of entry staff must know the case definition and they use it to detect possible cases, then follow available protocols. You need to monitor rumors and other alerts, basically from the health facilities, the media, politicians, and community. Then you respond to each alert from rumor. You investigate to see if the case definition is met. You investigate by the lab, send the samples to the lab, then identify and record the contacts, and they use the appropriate surveillance tools. When a suspect has been identified, that is the case meets the working case definition, then I've just repeated this case definition just for emphasis. If somebody meets this, and as you can see, we talked of any person with one or more of the following, any of these features will actually be suspected to be having Ebola, so long as the third aspect, which is the history of travel or contact with somebody who has been known to have Ebola. We have had so many alerts in Kenya so far, and for now, the total number of suspected cases are around 24. Samples have been taken, and for all of them have tested negative. How do you handle a suspect case? You refer to the Ebola case definition chart and immediately notify the sub-county health office and also the DDSR. You don your full PPE, isolate the patients and give supportive care. Withdraw 5 ml of blood in the red cup container, fill the Ebola case investigation form, our CIF, do triple packaging, and then send this to the lab. To transport the packaged specimen using the fastest means available to Kremlin Center for viral research or other designated reference labs, which you have mentioned, Kemri, Kilifi, and Kemri, Kisumu. If the sample cannot be transported immediately, refrigerate, but do not freeze the sample. We also inform anyone handling the specimen that this could be a biohazard, and you might even put the biohazard sign on it. You also restrict the number of medical support staff or personnel visiting or seeing the patient. Then you stop cleaners and other people going into the isolation room. Sometimes it happens that when such a case is identified, people want to find out what does a COVID patient, an Ebola patient look like, which can be dangerous if allowed to go on. Also, manage the waste appropriately. Then avoid contact with your body parts, something like scratching. Then you can prepare an adjacent room for staff to work to change their clothes there and ensure that they also, as anyone leaves the station room, they must change all clothes in the changing room. If the case is not in a facility, then you need to explain to the patient or the family the need for hospital care, arrange for hospital transfer, and if the subject has died, explain to the family the need for safe burial. Then after obtaining consent, coordinate funeral arrangements with the burial team. Start identifying, listing, and following the contacts, and have an Ebola contact listing form, and then the contact tracing and follow-up form. You need to fill in the case investigation form, later CIF. This anyone who meets the case definition must be line listed. Our line list document is the tool is MOH 503. Then you fill in a case investigation form. This has been customized for Ebola, so it is similar to our case-based investigation form, which is MOH 502. And for every case that meets the case definition, a CIF must be filled. Case investigation should also be completed for all suspect deaths, either in the community or in the health facility. Case investigation form should accompany all laboratory specimens collected from the suspected cases. As you send the sample to the lab, it should be accompanied by a case investigation form. Then you need to maintain a line list of all cases. The designated treatment center or the admitting health facility should maintain a line list of all suspected cases, probable or confirmed cases, and line list anyone who meets the case definition. The case investigation form and the line list should be submitted to the next higher level, and the surveillance team at the county and MOH level should regularly analyze data to describe, characterize the epidemic, and monitor its evolution. Well, the next concept we need to talk about is contact tracing. Who is a contact? A contact is any person who, without any symptoms, having had physical contact with the case or the body fluids of a case within the last 3 weeks. So the notion of physical contact, we may say that we can actually prove that there was contact and know that there was contact, but in most cases, just the mere fact that you're in close association with a particular person, say in a conveyance, then we shall assume that you actually had contact. Supposing you are traveling in a conveyance such as a vehicle, then it's always prudent to assume that that person was in contact with the guy who had been tested positive for Ebola. What are the contact situations? Number one, could have shared the same room or bed, could have cared for a patient, could have touched body fluids, or closely participated in a burial. When a suspected case is identified, all individuals that had direct contact with the case since onset of symptoms should be listed using the contact listing form. And you need to identify competent officers to be able to do the follow-up on a daily basis for the next 21 days from the date of last exposure using the contact follow-up form. The team can comprise of community health volunteers supervised by healthcare workers. The contacts must be observed daily, usually at home, and we quarantine contacts who are of high risk of infection, maybe a mortician who did a post-mortem on a confirmed case. That is a very high-risk individual that might need to be quarantined in the facility. Monitor the body temperature at least once, and where possible, twice daily for the 21 days after exposure. They are supposed to report to the local facility if they develop fever. Then febrile contacts should be evaluated immediately. And if anyone has temperatures of more than 38.5 degrees centigrade, must be considered as a new case and be isolated. So in the event that a contact develops fever, you treat them as a suspected case, and they have to be isolated and tested for Ebola. Community education. Of great importance recently is we need to educate the community on the risk factors, which we call risk communication, as well as community engagements. There are some activities that have been shown to actually propagate this outbreak. Like a very touching one is bathing or touching the corpses. touching blood or body fluids of sick individuals, reusing injection equipment or needles. And then, of course, there are some occupations that pre-expose you. Hunting, also preparing and eating bushmeat has also been associated with transmission of Ebola. Communities should also be urged to report any suspected case immediately to the nearest health facility or to the emergency operations center nearby. There's need to establish alert desks at the various health facilities and to widely disseminate toll-free numbers. And then members of the family should be encouraged to call in and when they have a suspect alert cases or when they have any query. All health facilities should also have an alert desk. The facilities are supposed to be reporting on a daily basis. And we know that during an outbreak, all health facilities in the affected community sub-county should provide daily updates, including zero reporting. Zero reporting actually shows that if you had no case, you report a zero. If not reported, then you are not sure whether there was a case or not. But this is what you call passive surveillance. Passive surveillance meaning that the lower level facilities moving up to the higher level. When you get an outbreak, in most cases, we shall have what we call active surveillance. The higher level seeking for data from the lower levels to the higher levels, like a county asking for this data from, say, the facility or the sub-county, and this likewise for the national asking for data from the county or the sub-county. This ensures that the county and sub-county teams monitor the epidemic situation. So we get reports from the lower levels. As we go up, the numbers will increase, because if we talk about the facilities, about 8,000 facilities reporting to 306 sub-counties, reporting to 47 counties, then coming to the national, having all the reports of the 47 counties. There's a notion of verbal autopsy. During an outbreak, there could have been community deaths that had not been explained. And what one needs to do is, when you establish an outbreak, you need to go back and get information from the community. This person who died, did he or she have certain symptoms that will help us establish if they could have met the case definition. So all community deaths should be verified and likely cause of death established. So if the investigation indicates that the likely cause of death is EVD, a case investigation form should be completed and the case should actually be line listed. There are so many cases in Uganda that had been found to be meeting the case definition, and they were classified as probable deaths and line listed. Contacts to the case should also be identified and followed up. We talked of doing a follow-up for at least 21 days for any contact. So when we do hospital-based surveillance, this is what we advocate for. The objective mainly is to ensure that the isolation of suspected, to assure proper isolation of the suspected cases. And as I mentioned earlier, for Ebola virus disease, the most important thing is IPC, and more IPC. So at the hospital level, the MEDSO has to designate one staff to be able to do the surveillance on each of the wards. Maybe it could go around each of the wards. If it's a big facility, you might have actually surveillance officers even stationed in various departments, and then an overall one to compile everything from the hospital per se and report to the next level. The surveillance person will make a daily follow-up from the designated staff from each wards, stroke sections, stroke departments. So what are the duties and responsibilities of the surveillance focal person? Identify the nature of the facility. Each morning, they will need to gather that information from the staffs. And then if anyone meets the case definition, then they might need to be seen immediately and detect and identify patients having signs and symptoms that are suspected of EVD. If an EVD suspect is present, they need to take the appropriate history, ensure immediate clinical examination, take the appropriate specimen, fill out the prescribed forms, assist in storage, proper packing, and dispatch of the specimen, then urgently notify the next level, which could be at the sub-county level or the county level, and eventually to the national level. So currently we have what is known as event-based surveillance. This is differentiated from what we call indicator-based surveillance. And the main difference being that when you have event-based surveillance, it is open almost to anything that is of public health concern can be reported. But when you do indicator-based surveillance, you only have priority diseases and conditions and events, which as of now, we have 36 priority diseases, conditions, and events. When you have event-based surveillance, you can report anything that is of relevance for public health or can really cause anxiety within the society. So under SEBS, we can have two signals that are directly or indirectly involved with the EVD. So the first one is signal number 1, which talks of 2 or more people presenting with similar symptoms in a community within a week. This actually is geared towards us picking the conditions early, where there are clustering of conditions. Supposing there were 2 or 3 people presenting with a fever and rash within a week, then that points towards a possible clustering of cases. Signal number 6 is actually referring to any event that causes public health anxiety or concern. So in case anything is abnormal, then that signal can be used to report. So on a normal basis, we normally have 6 signals, 1 to 6. But now with the coming in of Ebola threat, we have also designated signal number 7, which is basically the latest definition for Ebola, which talks about any person presenting with either hotness of the body, vomiting, diarrhea, headache, rash, red eyes, or bleeding, and has a recent 3-week travel to either Uganda or at that time there was the DRC, or having had a contact with anybody exhibiting symptoms of Ebola in the last 3 weeks. Okay, so this is what we're doing in terms of the SEBS activities, community event-based surveillance, the revision of the data capture and reporting mechanisms, that's including signal number 7, then rapidly conducting SEBS sensitizations at the points of entry, and then escalation of SEBS sensitization to all counties in the event that you get a full-blown outbreak of EVD. That's all I have for now. Merci beaucoup. Back to the moderator. Thank you.
Yeah, thank you, Dr. That was short and precise and very informative. And we'll be looking forward to hearing some discussions from the members. Personally, I had one question, and it was about the response team number. Will it be accurate if somebody just calls 719 as opposed to having different and many different numbers? Because it's easier to remember 719.
Yeah, okay. Should I take several and then respond?
Take that one as we go, Daktari.
Okay. Yeah, we have designated numbers, and 719 can still be can still be called, but the ones that specifically for our national team are the 2 numbers that you have provided. But it's still okay, and I think that can be, such arrangements can be made such that if there's any report from somebody calling the 719, then they can be diverted to our number. Thank you.
Okay, John is asking, in the rapid response team, I don't see pharmacists.
Okay, yeah, a very important question. And one of the persons that we normally have under the RRT is actually a pharmacist or somebody in charge of logistics and drugs. As I said earlier, that's not they're not cast in stone. You can opt any members that are required at that particular site, but pharmacists and logisticians are important members of the rapid response team.
Rapid response team. Okay. So members, kindly ask questions on the Q&A platform. It's open for all of us to ask. But while we're waiting, Dr. you said one of the key things, and we are happy to hear that there's a national task force, there's a surveillance team ongoing. But what I wanted to know is the regularly update. I know the media was done, but the regularly update of the surveillance and what is happening. Where can the common mwananchi, like some of us, find this data without necessarily calling you?
Okay. I think there's an issue of having a dashboard. It's only that we have not gone into an outbreak situation yet. But even as COVID, we don't actually have, in the event that we get an outbreak, then we shall be able to be providing regular, even daily situation reports of that. But as of now, only plans are in to have a dashboard for the suspected cases being reported, as well as actually giving information on our preparedness. There's an IMT, Incident Management team, and as well as the NTF. Those ones meet regularly. Some of the members here are also members of the National Task Force.
Yeah, so just to clarify, Dr. The dashboard, like the one we have for COVID, it's for the people who are infected and all, yeah. But my understanding from the slide, it was more like a surveillance, like how many people did we suspect and how many samples have we done? And I don't, of course, it's not something that is like a daily report, probably perhaps fortnight, perhaps weekly. But if I'm just interested in knowing, since Ebola was reported in Jinja, how many surveillance have we, like how many people have we surveilled? Did we suspect? How was it handled? Because I feel like it's really a good learning point for us in terms of how prepared we are to handle Ebola.
That is something that the ministry can work on. I think we can have an inclusion of that on our website, as well as have the social media handles that the ministry has can be created and updated on a frequent basis.
Thank you very much. Cosmos is asking, are the PPEs same as the ones used for COVID-19? Same as the ones used.
By and large, the full PPE. PPE is not just the full gown. The PPE includes the normal things that you normally have: a mask and gloves. Those are part of the personal protective equipment. However, I know the question is more geared towards the full PPE, and the PPE, there's a slight difference from the PPE that we had in COVID because of the kind of exposure and transmission mechanisms. So the PPE are slightly different. The one for COVID might not necessarily be used during Ebola. So they are different.
Okay. Thank you. Actually, it's a very comprehensive answer. You go back to what is PPE, define PPE, then you can go from there. James is asking, on contact tracing, what do you mean by clinical contact tracing team lead? is contact tracing not being done by the PHOs and the CHAs?
Tracing is actually done by almost everybody. But the ones that we refer to is this. I am a case. I have met you. We had a meeting in the morning. I'm defined to be having Ebola. Then we do a follow-up view on a daily basis. When you are identified as a case and listed as a contact, we have an app called Jitenge Plus. From Jitenge Plus, once you are enrolled there, you're supposed to be giving us daily updates on how you are doing, and that is actually the way that it's actually designed to ensure that if you have a smartphone, then you can easily give us updates on a daily basis. And in the event that you start exhibiting symptoms, you will end up taking the most appropriate action if you develop fever and you're referred to the facility. So as it is now, contact tracing is not just done by a particular number of people. It is actually done by almost anybody, including any contact who has been listed as having had contact with a case. Okay. So as for you can do the follow-up by two means. Number one is using your smartphone, and number two, if you have a feature phone, yeah, there's a code that you have to send to a number that we can be able to follow up you on that. Okay.
Okay. Thank you very much. John is asking, can you kindly highlight the risk of morticians during the process?
Morticians, the risk of morticians getting that, I cannot really say that your chance is 50% or 100%, but you know that a mortician, given that he's dealing with dead bodies, is likely to encounter dead corpses that have had COVID. So he is at a higher risk of getting Ebola, as opposed to someone probably in the isolation unit or in the general ward. So it's only that it is higher. And as you know, most of this research on Ebola is a bit scanty, mainly because there are fewer number of Ebola cases. The outbreaks don't occur every other time. And even in outbreaks, like now, the Ugandan cases so far, we've only had 142 cases. And the research on Ebola might not be as easy to do as opposed to, say, diarrheal diseases and such. Okay, so the figures, I cannot really put a figure and say the mortician gets 50%, 100% or such. Thank you.
But that would definitely be a very good information to know, like perhaps from the 19, how many were morticians, how many it would inform on the best people to target even during training.
Sure. No, yeah, our trainings actually capture, trainings capture everybody. And we even had so many trainings even with the KNH, and the morticians are always invited. And you can testify that I've done those trainings in KNH quite a number of times, and the morticians also invited.
I'm saying in terms of knowing the implementation of it, there's training and then there's the implementation part. It always builds you, and makes the system better. So wanted to ask, why is it morticians are not being trained much in Kenya? And I think you've said you actually capture them, but maybe you can clarify that.
Yeah. Whenever you have trainings for Ebola, we target everybody in a facility or even in the community. The KNH team will actually agree with me. I had been doing some surveillance trainings with Dr. Njenga and the teams. And the good thing about KNH is that the morticians and everyone else, even the person manning the gate, were involved in that. Because unlike in the past where Ebola would actually just be confined to the healthcare workers. Nowadays, and somebody having Ebola, usually in the past, you could actually die even before you transmit it to somebody else. But unfortunately, with the mutations, as has been noted in West Africa, that that particular outbreak, the virus was not as virulent as the other ones. So somebody will walk around with Ebola, unlike what was happening in the 80s, 90s, where Ebola would come, and the main feature having been bleeding. When a few guys have passed on, then it was not being passed on easily. But with the mutations now, it has become even somebody walking around with Ebola, which is not the case in the past. So it's always important to train everybody.
Yeah, sorry, Dr. I missed that part. I think it wasn't very clear.
Yeah.
As mutation happened?
No, there are mutations that have already happened with the Ebola virus. It's not the same Ebola virus that we were having in the past. So you look at now, in the past, you could get an Ebola outbreak, and within a week, it has affected a few number of people, and then it is contained, even self-contained on its own. Okay? Yeah. Yeah.
So another very important question is from Victor Machana. He's asking, I'm wondering about the suspected case in Kakamega Hospital sometimes back. Yeah. How far did the contact tracing go? But I think even more, can you, Dr. Can you give us like what has happened, you know, like so that we can know in a reality practical perspective, what has been ongoing in the background?
Oh, we have had quite a lot of activities done, and the suspected cases we're getting is because the public and the health personnel are now have the case definition, and that's what I shared. And I'll also share the one for the community level as well. So anybody meeting the case definition has been listed. And so far, we have, as I mentioned earlier, we have a total of 24 cases that have been investigated, and they have all turned negative. The point about contact tracing, we contact trace. If you turn negative, then there's no point of doing any contact tracing. In the event that somebody turns positive, the active participation of that becomes even more crucial. But as of now, Kenya has not recorded any Ebola case, and whenever you have met the case definition, we have done the test, it always turned out to be negative. But in the event that they turn out to be positive, then the personnel are very much aware that you have to list all the contacts, which is even more aggressive than the contact listing and tracing that we did in COVID-19.
Okay. Sorry. What are the steps one should take on a suspect in the peripheral centers where transport is a challenge to improve on their patient outcome and reduce transmission? Daktari, what are the steps one should take on a suspect in the peripheral centers where transport is a challenge to improve on the patient's outcome and reduce transmission? Hello? Doc, I don't know if I'm audible. I think Dr. Samuel.
Oh yeah. Okay. Yeah. Thank you. I was actually muted. As I was talking, I was actually muted. Yeah. So that's what I was saying. I muted myself. But that's what I was saying. It is one of the things that we have highlighted in one of the scenarios that I gave. You could have somebody in the community, and while in the community, the CHV, the community health volunteer, was normally contacted first. If you get in such a situation and there is no transport, as always, the first thing to ensure about yourself is safety for yourself first. If you don't have the PPE, then you cannot respond. But if there is a PPE, then you can handle the situation at that level. If you have other, say, most of the times an Ebola case dies because of hypovolemia. So what can you do? You can institute IV. If you get an IV access, provide some fluids, maintain that, because one of the biggest problems is hypovolemia. So the most important thing to do as of when you get that particular case, stabilize the patient hemodynamically, and then look for the safest way of referring them to the isolation center. All the counties must now be having a designated isolation center. So if you're at that level, it's good to contact the next level. They'll provide the transport to take you to the isolation center. But as I said, always, your safety is paramount. Safety first.
Safety first. I think we have that very clear. Douglas is asking in regards to surveillance on the non-gazetted crossing points, the Panya routes with our Uganda border.
Mm-hmm.
Are we surveilling them?
Oh yes, sir. The problem with the porous border is quite a big problem all over. But what we have done as a ministry is what we call POPCAP, and it is basically trying to find out what routes do people use apart from the official border points. It's POPCAP, population connectivity across borders. It's called POPCAP, connectivity across borders. So you basically try and map the areas that people use and where do they end. It's a big problem, but the best that we have done is actually just to kind of get to know the unofficial border points where guys cross over illegally. But it's a big problem. Thank you. Over.
Yeah, thank you, Daktari. Another pertinent question is on pre-hospital care.
Yeah.
So Norbert is asking, how prepared our ambulances crew in handling cases, considering that the symptoms are not very specific?
Yeah. Now with the threat of Ebola, we are doing trainings all over the country, but you started with the high risk, what are called 20 high risk counties. But as it were, there's still much more needs to be done. We are not yet there, but we are doing as much as we could to just ensure that everyone gets this message, particularly all support staff who work in the hospitals. That's including morticians, the ambulance drivers, and the EMTs, emergency medical technicians, were available. Thank you.
Yeah, thank you for that, Dr. Because pre-hospital care is huge. We saw the role they played in COVID, especially because we can't set up the units everywhere. So kudos to.
We still have a long way to go, but we are trying as much as possible.
Yeah, we have to start somewhere, and we started on the right foot, I think, or the best foot. In case of death of a suspected case, especially in the community, who should take the sample? Is it only the pathologist, or even the lab team can assist in the same?
Well, as I mentioned earlier, with Ebola, it's always IPC, and IPC. If you have a clinician who is part of what you call the burial team, the clinician can be able to take that sample and send it to the lab. So due to the limits or scarcity of PPEs, we would like as much as possible, somebody putting on the PPE should actually be able to do several things as opposed to just, now if a clinician is seeing the patient and seeing the dead body, and he puts on the PPE, then that person should be able to even take the sample. It should not just be left and said that it's only laboratory staff can be able to take that. As much as possible, let us have the task shifting and ensuring that we, as much as possible, minimize the use of the PPE. That's what I'll advise. But I wouldn't say here that it is the role of any person that is a must this person to do it. Use your own discretion at that particular site. Your own acumen will guide.
Okay.
Over. Yes.
Yeah. I think you've captured most of the questions. Some of them are just more or less repetition. Let me read this. I kindly ask, how can we access the awareness banners, not necessarily for EBD, but also for other disease outbreaks? Awareness is spread more also even in the community pharmacies. During the COVID-19 scourge, one had to download from Cyber Cafe. Kindly assist.
Okay, yeah. Thank you for that question. As one of the subcommittees of the National Task Force, there is a committee on risk communication. That is actually the team that works on the media messaging, works on the banners, works and all that. So it is just a matter of getting in touch with the team, and then you can be able to provide. Okay, you're talking about just being downloaded at the cyber cafes. You can be given the soft copy. Can be given a soft copy, and if it needs be, you can print it. But even as at the national level, there are plans to actually do those the banners and do the posters as well. Actually, the designs, I think, for the last two weeks, I've been seeing that communication. So just getting in touch with the National Task Force team members on risk communication at the national level. Thank you.
So thank you. I think you've answered most of the questions, but there's a lot of emphasis on training of morticians, Daktari, from the conversation. I think it's a helpful feedback from the audience, and please don't hesitate to give us the gaps and where we can improve. So, Doc, do you want to give us a parting shot, and probably also, before you even, maybe Dr. Maritim would like to say something?
Yeah, that's okay.
Okay, I think she's probably not able to speak, but with us also is our Director for Quality Healthcare, who's actually, IPC is actually one of the units under.
Amina?
Yes,
Amina, I can speak briefly. I'm in a noisy place, but allow me to speak. So thank you so much, Dr. Kadibane, for an excellent presentation. Dr. Kadibane was actually my classmate in MBCHB, so I'm really happy that he's given such a great presentation, clarifying the role of epidemiological surveillance and contact tracing, and redefining for us the case definitions that we are currently using. One of the things, or one of the questions that came from the audience was around the PPE that needs to be worn when handling patients with Ebola. And I think the question was trying to link it up with COVID PPE. So currently, at the level of the National Task Force, we are not recommending repurposing of COVID-19 PPE for use in Ebola. So for Ebola, what is important to note is that your PPE should be waterproof. It's full PPE that's covering the entire body, including the mucous membrane. So N95 mask, goggles, head protection, plus a full waterproof PPE, and also a waterproof apron to protect from contact. So remember, we've talked about the mode of transmission. It's largely contact transmission. And we say that the virus can penetrate skin that has microabrasions, intact squamous cell with microabrasions, but can also penetrate mucous membrane. So we're talking about things like the conjunctiva, the nasal mucosa, the oral mucosa. So that's why we are recommending full protection, PPE, and this was alluded to in the session that was presented last week on Friday under IPC. So I'm encouraging all the people who might have missed that session to go to the KNH webinars and just look at what are the IPC requirements for EVD, just to highlight that. And then remember again, all these webinar series are interlinked together. So if some of you might have missed some of the previous webinars, please go back to the KNH webinar platform and you'll find the recordings all available there for your reference so that you don't miss any important aspects. So today's session on epidemiological surveillance was really to make a linkage. What should we do when we have a suspected case? What are the numbers that we need to call? How do we reach the rapid response teams? And when they come, what should they do? But in the meantime, we need to know what we are doing with them. Suspected case whose will be under investigation until the point when we have that confirmation. So that was really the essence of today. But I'm encouraging all people who might have missed other previous sessions just to go to the KNH webinar platform so that we can have that linkages between the different sessions. Thank you very much, Amina, and thank you for great moderation.
Thank you, Dr. for your kind words and for your valuable input. Dr. Kadivane, I am sure I got your name correctly now.
Oh yeah, at least now it is Kadivane.
I'm scoring 10 now, right?
Yeah.
Yeah.
Oh, my parting shot would be awareness of COVID is for everyone. And the most important thing to always remember is that the mainstay of any health problem is surveillance. If you don't know the numbers, then we cannot respond. So the most important is let us continue being keeping abreast with what is happening and ensure that we get all the numbers. Better to have somebody who is suspected and does not test negative than to have somebody who was missed and test positive. So for us, we say it's good to have a very sensitive case definition so that we capture all. Thank you so much for having allowed me to have this talk today. Asante.
Yeah, asante sana daktari. At some point I thought I had COVID, but I just wanted to get your input on this and maybe for me and the audience to get a better idea.
Yes.
With Ebola, one case is considered an outbreak.
Yes.
Is this the same as other diseases like cholera, for instance, because we're having a problem with cholera right now?
Yeah.
What constitutes an outbreak with cholera? Is it one as well, or is it many cases?
They are, as I told you, in indicator-based surveillance, we have about 40, now we have 36 diseases that have been followed up as priority diseases. And all of them have different thresholds.
Yeah.
There is what we call alert threshold, and then there is what we call action threshold. For the alert threshold, there are diseases like cholera, like Ebola. One suspected case is an alert threshold. One confirmed case is an outbreak. So whenever you suspect, that's already an alert. When you confirm, one case is an outbreak. Cholera, Ebola, that's the same. However, for measles, we have some certain number of cases for you to call an outbreak. The same case for malaria. Malaria is endemic in some areas, and what constitutes an outbreak is when cases become more than what is normally expected.
That's
baseline. What we call an outbreak. So there's normally what we call alert thresholds. These alert thresholds are set by looking at the needs in the past, the number of cases you've had, and then now coming up with saying that normally we have 20 cases of malaria. Right now we are doing 70, so there must be a problem. So different diseases have different thresholds.
For
Ebola, for cholera, one case suspected is an alert, one case confirmed is an outbreak.
Okay. And then I'm sorry, but I'll just keep asking. Like
continue.
Right now we are having the problem with cholera, and I believe it was Emily who had asked, where do we get the other diseases? So now this particular other disease named cholera, and there's some sad cases I hear of mortality in even the young at the moment in Nairobi. Where do we get such information? Is it something available to the general public? Where is it published, and where can we get them?
Well, currently we have a line list that is being populated all the way from the lower levels coming to the national, and that is information that can be made available. But it's something that we can work on and be able to provide regular updates.
Okay. So then, yeah, Daktari, thank you very much for giving us a very informative, brief discussion. Thank you for responding to all the questions with such zeal and answering it conclusively. So today is a unique day. We're going to have 2 webinars. The next webinar will be at 7 p.m. It's going to be with Dr. Syokau Ilovi. She's a consultant genetist, and we're going to discuss about approach to a patient with a genetic disorder. So the webinar starts at 7 o'clock. Very interesting discussion. I like her perspective on GMOs. Kindly, if you have time, tune in and listen. So as usual, if you want to get the other series, you'll get it at KNH Research YouTube channel, or you can get it on our website. And as if you also want updates, and hopefully when the cholera updates will come, we'll also be updating those stats on the KNH Research Twitter handle, so that people can be more aware and informed. So without much further ado, thank you guys, and see you in the evening if you'll tune in. Bye-bye.
Yeah, thank you for the opportunity.
Thank you for coming as well. Bye.
Thank you. Bye-bye.